Good to go.
Good to go? Okay. Good morning, everyone. I'd like to thank the Office of the Secretary of Health as well as the Johns Hopkins Bloomberg School of Health for joining us today. We've seen Maryland's positivity rate creep up over the last few weeks, and our Hopkins positivity rate for Maryland is over 6%. These rates are preventing us from getting back to normal. Our children are in school. We're shut out of a lot of interstate travel. Unemployment is way too high and many businesses are still struggling. I'd like to better understand why we cannot seem to push this positivity rate down to levels that would allow us to further reopen our state. I hope our plan is not hooked to whether President Trump's latest vaccine pronouncement is, because I do not accept that our current situation is the best we can do. I'm looking forward to better understanding our challenges and how we can help today with today's meeting. And I know it's been since August, so this is an important meeting in terms of update. Thank you. Mr. President.
Thank you, Madam Speaker, and pleasure to see you virtually again, and to see all of our colleagues virtually and members of the department. Post Labor Day, our first convening. I think I would be remiss if I didn't sort of start on the thing that is certainly keeping myself and my wife up at night, which is the virtual schooling, which has been an extreme challenge. I do want to make a note and thank the educators who, in the springtime were forced into a very, very difficult situation. The level of competence and technology usage and thoughtfulness that has gone in over the summer has been a remarkable change from our personal experience, but I'm hearing it from parents across the state. Teachers are doing the absolute best that they can in very, very, very difficult and different circumstances to try to reach kids. And despite all of that, we know it is not the same as in-person learning. The governor, right before schools were to begin, urged in-person learning. I don't think there's anyone that would disagree with the importance of getting kids back into the classroom for the social emotional development that's needed. I would like to deeply urge the State Department of Education to take a much more urgent approach to providing real guidance across the state that will give districts the ability to make the difficult decisions about how to bring students back. The initial metrics, I appreciate the Department of Health guiding with some very initial metrics. It's not quite sufficient. We are going to need some additional metrics around PPE distribution and quarantining policies that will give parents and families the confidence that we have control over this virus and how to move forward, bringing kids back into classrooms successfully. This is an economic issue. It's affecting childcare and parents' abilities to work across the state. And it is an urgent challenge ahead. So look forward to hearing the Department of Health and their thoughts on this particular issue. Two other issues I want to just briefly touch on. The second issue is that of the vaccine. There's been a lot more conversation. I had the opportunity yesterday to speak to one of the principal investigators at Johns Hopkins University who's working on one of the vaccines in one of the phase 3 that's in phase 3 stage. There were some enlightening facts that I hadn't heard before, and I wanted to pass along. The first was that while there has truly been remarkable progress on the vaccine front, the distribution of the vaccine upon emergency authorization licensing and then full licensing is still, in the absolute best case scenario, 6 to 8 months from the date of emergency authorization. So in the perfect world where we would have emergency authorization in October or November, that starts the clock for another 6 to 8 months before we can realistically believe that a vaccine distribution program is going to be able to reopen our economy. And I think hearing that from somebody that is running one of the trials was pretty eye-opening to me. I think we've looked at this vaccine as a solution, but the logistics that go into it are enormous and Herculean. And so I think it's really important that we keep that in mind moving forward as we make decisions about the future of Maryland, that even with an amazing light speed approval, it is still 6 to 8 months from that point until we'll start to see the impact on herd immunity overall. So there is time to go in this ball game. The second fact that I had not seen publicly reported elsewhere, for the 3 vaccines that are in the trial stage of the phase 3 trial, each of them is using a pool of 30,000 individuals. 15,000 received the vaccine, 15,000 received the placebo. There have been lots of public comments about the diversity of those trial applicants, of those in the 30,000 person cohorts, so that we can have the understanding of the disparate impact. There are 2 groups of individuals who are not eligible to be a part of the trial, or 2 cohorts. It's women of child rearing age who are on birth control either through a pill or IUD. Those are the only eligible women who can be in the trial. If somebody uses some other mechanism, condoms and spermicide, or other birth control mechanism that is not the pill or IUD, they are not permitted to be in the vaccine trial. This means that for a number of women who are not, who utilize a different form of birth control or not, we will not have data about the impact of these vaccines on that population. This is something that struck me as a pretty important fact to get out there. And I think I hadn't seen publicly reported that I think is important that people really understand that even with emergency authorization, there will be large cohorts of the population with whom we will not have data. The other group is pregnant women. Pregnant women are not part of any of the trials for the vaccine. Certainly this is a population in Maryland that we have tried to focus on maternal health, and we will not know how these vaccines will impact pregnant women even after emergency authorization. And so it's something that I think that we need to be monitoring very well, and hopefully the Department of Health may be able to speak to some of this. The last issue that I want to mention is that of the budget. We certainly received some positive news in the 2020 closeout. The unemployment benefits from the pandemic unemployment, the additional $600 a week, and the PPP program that kept a number of businesses from laying off workers seem to certainly buoyed our economy in Maryland. Withholdings are much higher than we expected. The sales tax took a dip, but not nearly as much as we had predicted back in April and May. That said, I think it's very, very, very important that we caution what the future looks like. The PPP and unemployment are due to expire. Should those programs not be extended, there is a fiscal cliff looming. And with the revised estimates, it appears we are still looking at about an $800 million deficit for FY21, this current budget year, even with the write-ups from the prior. And then even more challenging is that we have in fiscal 22, we are looking at a $3.4 billion fiscal deficit. So we know that what happens in November will make a big difference and whether or not the federal government moves forward with support for state and local governments. But I think we have to be very, very mindful that in this recovery, there is going to be a lot of requests for support, and we have to, of course, constitutionally required to balance the budget. And so we're just going to have to keep this in mind as we face these challenging times ahead. And so as we look into the fall, I think this will underpin a lot of our work as it comes to the recovery. With that, I don't want to take up any more time and do very much look forward to hearing from the Department of Health. We are pleased to have the Secretary of Health, Secretary Neal, the Chief Operating Officer, Dennis Schrader, and the Acting Deputy Secretary of Public Health Services, Dr. Jinlene Chan. We are very pleased to have them. And I think there are questions about what the fall looks like. We are very appreciative of their time so that they can provide their perspective on how we should be approaching the months ahead. Without further ado, Secretary Neal.
Thank you, Mr. President. Madam Speaker, it's a pleasure to be here. Can everybody hear me? Before I get started, I wanted to thank the General Assembly. I hope everybody got the news yesterday about the lower rates for the individual markets. This was something that we did together 3 years ago. You all provided a revenue source and the support for our waiver, and we got another 12% reduction. It has an added benefit because a lot of people who lost their employer-sponsored insurance during this pandemic at least had another alternative to seek affordable health insurance. So this remains, I think, something that we all should be very proud of. Mr. President, I'd like to respond to your remarks about the vaccine. I never in my wildest dreams thought that we'd have anything before February or March of next year, and I think that sometimes is optimistic. For the next 6 or 8 months, our job is to use the tools we have to coexist with this virus so that life can go on, we can get our children educated, people can go to work, but we've really got vintage 1918 tactics to work with. That's why these are so very, very important, and you'll hear more about our masking initiative later on. In summary, we've done about 2.2 million cumulative PCR tests in the state of Maryland, with testing volumes that exceed 20,000 tests a day within the state. We have 33,000 cases and over 41,000 contacts reached and interviewed by contact tracers throughout the state. You all know how important that is to determine the source of new infections. We've distributed over 78 million pieces of personal protective equipment, and the requests are being fulfilled as we speak, including supplies for schools and also the needed materials for the upcoming November elections. Mr. President, I'd be happy to have a sidebar chat about the metrics that you would be interested in regarding PPE. And the next is very important as we face the fall. We've identified approximately 6,700 surge beds, and we continue to make advanced medical tents available, ICU modulars, and alternate care sites available for COVID patients. As we face the fall and the possible flu season, this could be a very challenging time for our healthcare system because what are the symptoms of COVID? They're flu-like symptoms. So if you get flu-like symptoms and have flu, you're going to go to the hospital or a doctor. And if you have COVID, you're going to go. And so I think while I won't say dodge the surge in last spring, I think our high water mark was like 1,710 people in the hospital. We could well have a second surge that could be even more serious than what we faced this past spring. So coexisting and trying to find ways to successfully pursue life and keep the population safe is the job we have, I think, for the next year, a year and a half. It will certainly get easier if we do get a vaccine in some quantity, but the tactics that we're using now and we'll use in the future will still be necessary because we're not going to be able to vaccinate everyone. With that, I'd like to turn it over to Dennis to talk a little bit more in depth about our testing efforts. Thank you.
Thank you, Mr. Secretary, Mr. President, Madam Speaker. It's a pleasure to be here. I'm just going to go through a few slides here to give you the highlights of where we are. On this slide, I want to emphasize the fact that early on, we made sure that every Medicaid recipient had access to testing, and that's been going very well through their managed care organizations with no pay or no limits. We've also been providing a great deal of testing through community sites. Particularly, we have the Six Flags site and the Baltimore Convention Center have been providing a lot of testing, but we've got testing throughout the state. In addition to that, with local health departments providing an enormous amount of support. Also, we have seen a mitigation of the turnaround times for PCR test labs, and they're now down around 2 days is the median, so we're feeling a lot better about that. We'll talk a little bit more about the antigen tests that were purchased. That's an emerging technology. And then we're also reviewing other rapid test platforms which are coming onto the market. If I go to the next slide. This slide shows the current, as of today, number of beds that are occupied in Maryland, 347. That's compared to the, as the Secretary mentioned, the high watermark of 1,711 back at the end of April. So this is good news, but we're monitoring this very closely. What we're finding is 86% of the hospitals in Maryland have now reached pre-COVID levels of service. So a lot of that excess capacity is being absorbed by regular customers. On top of that, you add the COVID volumes, which you see here, and then we're looking at projecting the flu based on, if you think about it, the COVID volume started to hit in March, which was the end of the last flu season. So we're now going into the new flu season, and we're doing estimates of what those implications are going to be. So we're watching surge beds very carefully. Next slide, please. This slide gives you the positivity 7-day moving average with plus 35 and older, 2.64%, and less than 35, 4.85%. I would want to mention, and we have recent guidance that came out of CDC on September 3rd, and they actually, which is very helpful because it does recognize now the 3 different methods of doing positivity. Maryland uses the method that CDC uses, but there are 2 other methods that are recognized by CDC in this document. So this really clears up a lot of questioning that's been going on about what's the right way to do it. And I'm sure we'll hear from Dr. Inglesby later. Hopkins is using the 3rd method out of 3. So that's all good news. And I'd commend this September 3rd document from CDC to everyone, and we can get it to you if Webster can make sure it gets sent over to you if that's helpful. Next slide. This is a breakdown of the sources of our testing throughout the state. We've done over 2.2 million. You can see the percentages by different sources. The private sector is doing a tremendous amount of testing. You can see, about 50% is in urgent care hospitals, provider practices, and retail pharmacies. About 17% total for assisted living and nursing homes. And then the community managed that ourselves and the local health departments, about 13%, and then a smattering of other sources for the rest of the testing. So there's a lot of testing going on in different places, but we are heavily reliant on the private sector, and they've really stepped up in this instance. Next slide. I just commend you to the website. It lays out the 220 active sites in Maryland. I think we've talked about this before, but just a reminder, you can go to our website and it'll take you to the sites all around the state for those that want to get tested. Next slide. There's been questions about the use of our test assays that were acquired, the Korean test kits, lab gun. As of just yesterday, we've used over 210,000 of the assays. We've deployed 130,000 to a company called Scion. We've been working with them since the spring, and they've now used over 72,000 of these assays, and 370,000 have been deployed to the UMB UMPA lab, and they've used over 138,000. So we're moving that along. We've been gathering samples from campuses and nursing homes and community-based sites, and so those tests have been a godsend to us, particularly back in July and August when we saw that national burst in the south and the west and southwest, it buffered those turnaround times for us. And I also mentioned that on the September 2nd, the procurement was approved by the Board of Public Works. Next slide. The last thing I'll mention is, the antigen and rapid point-of-care testing. The Secretary Neal issued an order about a month ago that allows us to use these point-of-care tests in the state. The antigen testing, of course, is a new method. The federal government is pushing out tests to our nursing homes from two companies. We're attempting to buy, we have bought 250,000 from Becton Dickinson, and we're in the process of trying to buy another 250,000 from Cadell. We'll be using them as a backup to the nursing homes, but we also are looking to use them in other congregate settings like corrections. We're talking to the universities about these kind of tests. There's a lot of work to be done in making sure that they're used effectively as an alternative to the PCR-based testing. And with these tests moving out into the nursing home environment, it's pushing us to move that process along, working with our clinicians in the department. And I think that's my last slide, and I'll turn it over to Dr. Chan.
Hi, good morning, Madam Speaker, Mr. President, and members of the work group. Thank you so much for having the Maryland Department of Health here. And so I wanted to pivot a little bit to build on what Deputy Secretary Strader has reported in terms of where we are with testing. Secretary Neal talked about where we are with PPE and contact tracing. And as we looked at our metrics over the summer and saw some of the increases, we know that on August 3rd, Governor Hogan issued a more expanded face mask order that extended the use of face masks in more areas across the state. And that built on the face mask order that was issued on April 15th. And so we continue to watch our metrics very closely, but emphasizing that masks are really critical to continuing to keep Maryland open. And so with that, we have pushed out a Masks on Maryland campaign. It's the first phase of a three-phase messaging that we want to push out to our communities. It focuses certainly on wearing a mask and the benefits of it and how it will allow us to carry on doing all of the things that we do and that we all want to do in life, not just as a barrier. So we produced some toolkits related to wearing of masks, one specifically for Spanish-speaking audiences that have been shared with other state agencies, local health departments, and our community-based partners. I believe we have a brief video. I don't know if it's able to be played, but we can share one of the campaign messages.
Hold up.
So thank you. So you can see it's very catchy, and we really want to push this out and have people understand that this is all connected, that the wearing of masks, the continued need to keep our hands clean and physically distance will help us keep Maryland open. In addition, next slide, please. Related to our Masks on Maryland campaign, we're also have been supporting mask distribution events, starting with some of our testing sites. This allows us to reinforce the message that we're putting out with our campaign. So some of the events have been very much a partnership with some of our local community-based organizations, including the NAACP and some of the local chapters working in Prince George's County and Baltimore City. And we've also had some events in Hartford and Ocean City, and we are looking for ways to expand that and partner with other community organizations in the future. So next slide. One of the key tenets as we have continued our response efforts to the COVID-19 pandemic is minority outreach. And so as you could see with some of the materials that we've developed and others that are currently in development, it is important to make sure that we also have messaging that is culturally appropriate. And so to that end, we have engaged and met with individuals who represent community organizations around the state to get feedback, and they have provided information on where we might target messaging, community influencers and others who may be helpful in partnering with us to get the message out. In addition, we've been providing support to HBCUs with some of their research surveys and projects. And we have been able to provide through CARES funding $1.2 million to some of the larger jurisdictions to support some of their very targeted COVID-19 outreach to minorities. And so that has been important kinds of support that the department's been able to provide to state partners or to local partners. Next slide, please. One of the areas I wanted to highlight for the work group is our Hispanic Outreach Task Force. And that came out of a number of conversations that we have had internally, that as we were seeing the impact of the COVID-19 infection on minority groups, and as partners were talking to us, importantly, our Baltimore City Health Department partners, Johns Hopkins, and others, highlighting some of the needs in the Hispanic population and communities, beginning in Baltimore City. And as a outreach from that, we convened a group of partners that represents the state as well as the city and local community organizations to really begin to understand and develop interventions that might support those communities and prevent further spread that we were seeing there. So some of those supports include in the areas of human services, certainly with contact tracing, prevention, mitigation, and housing solutions. And now we are exploring a pilot program with those partners to be able to support families if there is a positive case so that they can isolate without worry about their families or other wraparound needs that they might have while they're in their period of isolation. So that is a program that is being explored right now, and we look forward to seeing how it goes and potentially expanding that to other areas of the state. Next slide. Just as another example of some of our Hispanic outreach material, this video talks a little bit about contact tracing and the importance of contact tracing. And so if we have time, if you would indulge us, we have one other short clip that we can share with you.
Es crítico que cuando nos llaman haciendo el rastreo de contactos, contestemos. La información personal que estamos pidiendo en esta llamada es totalmente protegida. Es solo para el propósito de ponerle un paro a esta pandemia. Esta es una acción que podemos hacer que realmente puede salvar vidas. Si es MD COVID, por favor, contesten la llamada. Responder, conectar, recuperar.
So, as you could hear, what that is about is encouraging individuals to answer the phone when MD COVID calls, when our contact tracing program calls. And so at the end, it is answer the call, connect, so that we can recover. And so those are really critical messages that we continue to push out. I know that there are continued questions about our contact tracing efforts, and we want to make sure that people understand it to the greatest extent possible. And so this is the kind of outreach material that we're using to be able to get our messages out. So next slide, please. So to that end, you can see where, just as an overview of our contact tracing efforts, and this is cumulative. So the data starts in mid-June, and that's really when our contact tracing system really got up and running. That is not to say that contact tracing was not happening before, because local health departments are really critical to all of the work that we've been doing as part of our response, and contact tracing is certainly no exception. You can see that when you look at the total number of cases reached and interviewed, that we have about 44,000 cases that have a phone number, and so that's really where our starting point is, and we've been able to reach the majority of individuals and with a total completed interview, which is really critical. The completed interview then provides us information about contacts that they may have had within the 14 days prior to their onset of illness or their positive test, so that we can then identify and call those individuals. And so this tells you a little bit about the work that we've been doing. Both local health, this reflects both the local health department work as well as the work of NORC, which is our contractor for contact tracing. The ongoing components with our contact tracing efforts and program is to, as you have seen, to focus on the public awareness and the importance of contact tracing, to support our cases and contacts and providing them information and seeing what supports they might need to be able to isolate appropriately. And we, so those are some of the ongoing work. I know that we recently put out an announcement that Maryland will be working with Apple and Google on a new product, the Exposure Notifications Express, or ENX, and that work is in development. And so we are partnering with DO-IT, the Department of IT, at the state level, as well as with Apple and Google, of course, to integrate it within our system. So there is an implementation plan that's being worked on right now. And so let me move on to the next slide. I'm going to switch gears and close with talking about COVID vaccine. I think that's very appropriate, and appreciate President Ferguson's discussion and exploration of this topic. The Maryland Department of Health is right now in the process of developing a plan we're using as a base to start the work and the knowledge that we gained and gleaned from our experience with pandemic flu in 2009, and also, of course, with frequent calls with our federal partners at the CDC, FDA, and others. Operation Warp Speed, or OWS, is the name of the federal operation that delineates their efforts to accelerate the delivery of safe and effective COVID vaccine to states. And so the timeline to actually get the vaccine to us is very accelerated. They have reported that how they're planning to do it is going ahead and beginning manufacture of some of the vaccines ahead of approval, but only, of course, pushing out the vaccines once they are actually approved through the FDA EUA process. What we know so far, as part of our planning, is that the vaccines that are currently in clinical trials will likely take 2 doses, and at least a handful of them may require ultra-cold temperature storage, and what that means is that's a -70 Celsius, and that's you know, sort of the very, very cold freezer temperatures that we don't typically use. Our home freezer or other vaccines, for example, that may need freezing are typically more at -20. And so the ultra cold temperature and maintaining the cold chain and maintaining the stability of the vaccine is one of the many considerations that we will need to take into account, not just here in Maryland, but certainly across the country as we plan for deployment of the vaccines that may come out. We know that the first shipments, so when the approval does occur of 1 or more vaccines that are in the pipeline, that the first shipments will have limited numbers. So again, to the point that Mr. President, that you made earlier, we know that we're not going to get initially a sufficient quantity to be able to deploy it out to our entire high-risk population immediately, but it will take some time to be able to get the vaccine out and distribute it and provide it to the high-risk populations. And speaking of that, while the guidance, the specific guidance for who the vaccine may be initially prioritized for has not been finalized, we know that that is an ongoing discussion with the Committee on Immunization Practices at the CDC and others. They are the ones who normally discuss and provide guidance on the use of vaccines across the country. And however, the likely populations will include those who are at the highest risk of complications from COVID-19 disease, as well as healthcare workers. But more specifics to come. We do not have more information on that at this time. As I alluded to, we do have a number of planning efforts already underway. And so it includes vaccine tracking. We recently announced that we had issued a contract to Maryland Partnership for Prevention for a platform that we have some experience with previously called PrepMod, that we will be using to track flu vaccine as well as COVID vaccine utilization. And so we have been working with our local health departments on the rollout and use of this particular platform in recent weeks. Communication and outreach is going to be really critical. As we learn the results of and information about the COVID vaccines that will be made available after the FDA approval, ensuring that we communicate and educate the public. There will be a lot of questions that we know that we will need to be prepared to respond to in collaboration with our federal partners. And so the communication outreach component is not a small matter. It is really critical that people are informed of what the vaccine and have the best information possible. And then last, I noted, of course, some of the challenges that with this particular vaccine. So logistics and operational, to have 2 doses, we have to provide the first dose for the person, find them again. I think it's usually, the vaccine's out right now between 21 to 28 days later, and give them the second dose, and it has to be with the same vaccine they received. The cold chain issues, making sure that we deploy the vaccines out widely to make sure that the priority populations are reached. All of those things are being discussed right now. I want to just close this slide, while it's not on the slide itself, to emphasize that we are going into flu season. Flu season typically begins October 1st, and so we're at September 16th today. And so I can't emphasize enough the importance this year of making sure you get your flu vaccination. It is more critical this year than ever, so that we can prevent any complications of flu and prevent any potential surge into the emergency departments and our hospitals. So I will close there. Thank you. I'll turn it back over to the Secretary.
The next slide.
Next slide.
You may be wondering how we're going to spend our autumn. Well, there are 6 things on my list, and there may be more. I need to say at the very beginning, this is a huge logistical effort. This is like 90% logistics, and we've got to be able to hit our marks on that because so much depends upon it. We're going to expand and communicate the Mask on Maryland campaign and try to get it into every corner of the state. And simultaneously, we want to do a very vigorous flu vaccination outreach because so much depends on it. We are preparing, and there are meetings going on virtually every day for the COVID-19 vaccine deployment whenever it becomes available. We've gotten an early start because we wanted to be ready whenever it came. We need to roll out the new antigen testing and other rapid point-of-care test platforms because they're going to be vital in keeping the state open. If you think about it, if you got something that you can get results in 15 minutes, it works very well for the workplace, schools, universities, and other congregate sites, rather than send it off to the lab and get the results whenever they come back. This is far, far superior. In fact, this is the one 21st century tool we have, in addition to washing your hands, wearing a mask, and keeping away from each other. We need to refine our data analytics to improve our publicly available COVID data, and that's an ongoing task. And we need to integrate our contact tracing analysis with testing efforts for a more targeted intervention. It's happening now at a limited extent, but we've got to get better at it and more nimble. And then last, to ensure hospital surge capacity for COVID and flu. You may recall that the way we had to create hospital beds in March was to cancel, what do you call them? Elective surgeries and elective procedures to empty the hospitals. That was a very, very caustic thing to do to the patients as well as the hospitals financially. Now that we've got our infrastructure in place, we just need to watch this very carefully and make sure that there is enough bed space for whatever happens in COVID and whatever happens in flu and other respiratory problems that come up in the fall and winter. So that's what we're going to be about, I would say, for the next 8 to 12 weeks, and we are working very hard on it, and we're hoping that we'll have everything in place and things will go along swimmingly. That is a hopeful comment, not a factual comment.
Fair enough. And Mr. Secretary, to you and your team, I just want to say thank you and appreciate the in-depth presentation. It covered almost every issue that we were hoping to see today with detail, and just want to appreciate the time that went into providing this information so that Marylanders have this and can feel confident about the fall. Also, Dr. Chan, I got my flu shot last week, so following your advice.
That's great.
We have several questions from members. Let's start with the Chair of Finance, Chairwoman Kelly.
Yes, thank you. A couple of quick questions. One, we've heard almost nothing about the largely Medicaid population living in assisted livings, not the big campuses, but those in 2 and 3 people in a house, or 15 or 20 in a house. And what is the testing situation? What protocols have been required? Who is monitoring that? What can you tell us about those people?
The smaller assisted living facilities you're talking about.
Yes, there are thousands of people like that.
Yeah, we require, So we'll get you a more detailed answer, but let me just start by saying we have a requirement for every assisted living facility with more than 50 people to be tested, and there's an order out that causes them to do that, and then from there, we are encouraging the smaller facilities to follow the CDC guidelines, but because of the threat of potential outbreaks in the larger facilities and the impact, that's been where our focus is. We can get you more.
But now that things are more under control, we do need some kind of a plan to do at least some kind of a ballot sampling of people. We've got thousands of them. They're in places where nobody has seen them. You know, we've got lax regulations, and there's the medical regulation largely, so that's a concern. And my second question is about hospice patients. I've gotten recent mail from a number of hospice organizations in Maryland indicating that when we had to shut down the large nursing home campuses, they were denied access as if they weren't providing a medical service or a necessary service, and they weren't able to get in to see their patients. Has that issue been resolved? It's terrible to think of people dying and what they need is hospice, and if they can't get the hospice service.
Go ahead.
Madam Chair, this is Webster Yee for the Department of Health.
Yes.
Currently, the CDC guidance, the CMS guidance that was issued on May 18th, still, generally speaking, prohibits visitation in most circumstances. The one exception that our federal partners have given us is end of life, and so the state of Maryland has adopted the federal requirements. We're looking to see how we can make changes and to make the changes in a common sense and clinically safe manner. We're trying to figure out a way to do compassionate care as well.
Okay. Wouldn't you say that if you're in hospice, if that's been prescribed, you are in fact at end of life? And what you need most at that time is being denied from even a medical perspective. I'd ask you just to think about any reinterpretation or work with the feds to see what you could do there. It seems that people who are there because they need hospice services and can't get hospice services ought to be considered or redefined.
Happy to look into that.
Thank you.
Okay. Chair Prendergast.
There we go. Thank you, Madam Chair. Madam Speaker, I appreciate being recognized. Thank you, Mr. Secretary, for praising the bill the General Assembly passed, which the governor wisely did not veto, which caused insurance rates in Maryland to decrease for the third year in a row. It was the product of the Maryland General Assembly, Michelle Eberly from the Commission, the Exchange, and Al Redmer, the former insurance commissioner. We are grateful to have been able to pass a bill that could, for the third year in a row, decrease insurance rates. And we're glad that you recognize the efforts the General Assembly expended to do the right thing and that the bill was not vetoed. Beyond that, I'm also grateful for your responsible efforts based on science to control the spread of COVID-19 and keep the state prepared to handle outbreaks. As we all know by now, my husband sends me a nice chart every day where he graphs what's going on in the state. And I believe his numbers agree with the Hopkins numbers. The method he uses from the data you provide puts us at 7.6% positive yesterday, just FYI. That's not the number you use, but it is the number that I'm using and my other consultants, which are not always my husband. There are several NSA employees and former employees who know a fair amount about numbers who are doing these things for me. They are also my friends. I'm concerned, and I'm wondering if we in the state have our own positivity goal. Is it under 5% using Hopkins numbers? Where are we trying to get to? Are these new campaigns and efforts enough to get us to the goal? That is not to say we're not doing a lot of things. I tried to start with the fact that I do believe you are trying and moving in a right direction, but I'm concerned about where we are and where we're headed, especially given that the rates for the last 5 days, I believe, have been sort of trending up for the state.
Thank you, Madam Chair. I think there are 3 criteria that we watch very closely, and I want to gently push back. The methodology we're using is the methodology used by the CDC itself. There are 2 other valid measures, but it is only one, and that's positivity. We need to watch hospitalizations very carefully because even though they're a lagging indicator in many cases, that shows you what's going on the ground. And then the last is sort of a national measure, which is cases per 100,000, and that's one that's just arithmetic. And so today we have a positivity of 3.44 for a 7-day rolling average. Our hospitalizations are 347, which is on the low end of the range. We've been bouncing between 347 and 500 through most of the summer, but that's on the low range. We only have 86 people on in ICU, which is one of the lowest numbers we've ever attained. And then, once again, we're in the yellow, we're 9.5 cases per 100,000. Those are the three metrics, and I think they are complementary in a number of ways. They measure things different ways. The tactics that we're talking about, I think, is as much or as all we can do under the current circumstances. I'm going to be very hopeful with this point-of-care testing, because waiting even 24 to 48 hours for results is a delay. So when you're talking about congregate settings, schools, workplaces, and everything else, and you can get a test in 15 or 20 minutes, that's going to go a long way to help us get our arms around this problem. So I'm pushing everybody to get that in the works as quickly as possible, because I think that's our high gear. That will do as much or more than all the other things that we're doing, is to be able to get a better picture of what's going on out there.
I agree with you in part. It's good that you're using the rapid tests. I think that is a good strategy. It is important to remember that they are much less accurate, and the accuracy improves dramatically if you administer two tests relatively close together, because the statistics of that say that the percentage of it being neither a false positive or a false negative are much better. So you may want to consider that just giving a test once in a week might not be enough for instance, people at school. It may need to be repeated 2 days in a row just to make sure you get the same result. I think, yes, you're right. The tracing and the isolating is very, very important. Also, that your statistics, it's perfectly right to say, in my opinion, that all of them are relevant. But what I have been seeing in the last 5 days is a trend, and the trend is not good. And I think the trend is the omen of what is to come based on the most recent holiday that we had. I think that sometimes you can look at one thing and sometimes another. At the moment, we are seeing hospital rates reflective of the downturn that we had because of the good work that has been done in the state. But unfortunately, I think there was a lot of mask neglecting over the holiday and ignoring of the old-fashioned rules that we know at least have some impact on the spread. And I'm concerned about what it's going to look like for hospitalizations 2 weeks down the road or 4 weeks down the road, because really we're just beginning to see the impacts of positive testing from the holiday weekend. So there's timing and there's also testing. And I think that the testing, you can look at it. You know, we've been talking about granularity, your department and I, for a long time, and hopefully you're making some progress on that. But in this case, it's not exactly granularity, but it's about the timing of what you might be looking at that might be predicting what's coming down the road.
I don't entirely disagree. I'm going to be holding my breath until the 1st of October so that we see what the Labor Day weekend has cost us. There was a bump up after the 4th of July weekend. But again, this is living with this virus. We got 6 million people, and we got to figure out a way that we can go to work, get our kids educated, and do all the things that we're supposed to do, and still keep this within the bounds of safety. It's not easy, and it won't be uniform. There are going to be bumps in the road, but I don't see any other way to do it except to address it forthrightly, tell people what they should be doing, enforce it a little bit, and keep careful track of our results. And
then if
a lot
I
of
may,
those results are going to be localized results, and that's why contact tracing and everything else is so very important. So if somebody in your neighborhood had a great big party on a Saturday night, we need to know about it, because we need to interview those people, particularly if there are some positive cases that arise from that gathering.
I absolutely agree. If I may just say one more thing. Never mind. We'll just leave it there. I'm concerned that if we don't have a specific goal and we know what it is, that we don't have a plan to dial things back. And I'm concerned that we need to have an idea of at what point we may be dialing things back in the state, that the governor might need to take action.
I hear what you're saying.
Thank you.
Yep.
Next question is from Chair of our Education, Health, Environmental Affairs Committee, Senator Pinsky.
Thank you, Mr. President. Thank you, Mr. Secretary, for your presentation and all that you've been doing. It's greatly appreciated. You just mentioned education, and the Senate President talked about education about 45 minutes ago. And so let me go to that for a brief minute. You know, I guess 2 days before school started for many students, the governor announced 2 metrics. I think it was positive testing in cases per 100,000. He also mentioned that all 24 jurisdictions had met those. We also know that none of the 24 jurisdictions opened with all in-person instruction. And in fact, that very same day, Towson University backed off having in-person instruction. And I think and I won't speak for the Senate President, those 2 metrics didn't give a lot of direction and leadership to the 24 jurisdictions since they've already met them. And I think what a lot of local leaders are looking for is a more nuanced set of metrics that can lay a pathway forward for when to bring back elementary, when to bring back middle and high school students. And I think those 2 metrics alone didn't do it. And even some of the jurisdictions, the Garrett counties of the world, that have very few cases per 100,000 have not been ready to go full force bringing students back to in-person instruction. And we all know it's preferred. Parents, teachers, legislators know we need to go to in-person instruction. So that metric question, I think, is a very important one. You mentioned metrics a few minutes ago. But before you answer that, let me shift to the back end, not just of returning students to school. I'm trying to understand what the protocols will be if 2 students or 3 students or a teacher in a classroom come down with a virus, or 10 or 20 students in a school come down with a virus. You know, I've been looking to see whether you have provided to the administration some common protocols of how school systems should act, because if we have different protocols at the back end, Allegheny's going to look at Washington County is going to look at Carroll County, and people are going to have a lot of distrust, and they're going to be asking their superintendents and school boards, are you protecting my children? And without having a common set of protocols at the back end, which clearly you and the 24 local health officers are in much better position to develop, without those, I think it's very concerning about actually returning kids if we don't know how to handle those bumps in the road that are going to happen. You're absolutely right that this is a trial and error. You know, we don't want anyone to be the canary in the coal mine. We don't want anyone to be harmed, but this is a new reality we're experiencing, and we don't have a good roadmap, but we need some type of roadmap. So all 24 jurisdictions and school boards and superintendents sort of have a common path with some variability. Clearly, some jurisdictions with fewer cases will move much sooner than a Baltimore or Prince George that have had more cases. So if you talk about whether the metrics that the governor announced, and I don't know if they're your metrics, really are enough direction. Secondly, about the back-end protocols, a common back-end protocols that all jurisdictions could have in their quiver.
Thank you. I'm going to answer your question with a great deal of trepidation because nobody knows the public school systems better than you. But I would say that the metrics were the metrics that we had. And I think we were laboring under the reality that there are 24 school systems that have local governance. And it would be hard to enunciate a policy that was fair to both Baltimore City and Garrett County and everything in between. We worked very hard on some educational guidance, and I'm going to turn to Dr. Chan because she spent, I would say, 3 weeks working exclusively with the State Department of Education and others to try to come up with what we did come up with.
Yes, thank you, Mr. Secretary, and thank you, Senator Pinsky. So with the metrics, when we selected those metrics, it was with much discussion and, similarly to Chairwoman Pendergrass in terms of, which metric should we use, what's going to be the best. We wanted to keep it simple and as simple as possible to give some indication of community transmission. And we looked at all the metrics that we, have discussed and others, and landed on those two. And we looked at other states in terms of the metrics that other states use, including Pennsylvania and Delaware and New York, and positivity, test positivity, which is what we report out on, is one of those metrics. And that, though, has to be coupled with the cases per 100,000. Now, we do provide some guidance, and so that gives a sense of. Now, what we also provided and would encourage local school systems in conjunction with their local health officers. I know over the course of the last 6+ months, every superintendent has had at least one, if not daily, conversation with their local health officers. And that's critical because the numbers give a certain sense of the picture and the sense of community spread, but understanding the details and what underlies those is really something that can be done better at the local level to paint the local picture of what those numbers may represent, and understand what then that picture can, how that would impact on that local school system and the decisions that they make to bring kids back. Now, I would say that the guidance we provided, including with the metrics, did not say, all school systems can open back with no precautions, cast the doors wide open. It was very clearly to say within certain precautions, practicing social distancing, masking, temperature checks, hand washing, if all of those can be implemented carefully, then there may be some opportunities to bring kids back. Now, because every school system is different, in fact, every school building is different, the needs of different communities are quite variable. There needed to be some flexibility that we provided in our guidance so that local school systems, again, in conjunction with their local health departments, could develop programs, systems, and protective measures for the populations that they serve and for the kids that they serve. And I think that the secondary component in our metrics is that there is a, if we do see metrics changing, so increasing, making sure that people in the school system keep an eye on that. Now, it's not an absolute, we should close everything back down, but a check to say, okay, if you're seeing a trend over 7 days or 14 days, then we may need to take another look at what's happening and, again, reassess constantly what that impact is on the school communities.
Yeah, but Dr. Chen, how many students in a classroom or how many students in a school raise serious health problems? Does that really differ from Prince George's to Anne Arundel to Howard? You have the expertise, and the 24, let me finish, and the 24 health officers work for you. And I'm very concerned that parents are going to be distrustful if there's not some medical direction with some flexibility. For example, if there's an outbreak, just to say we have to be aware and concerned and flexible is nice, but in some ways it abdicates responsibility. And I think you are the center of the medical expertise. And look, if I were a superintendent, I'd be very nervous about opening up to know whether I had enough PPE equipment for the whole year. And also, what do I do when there's an outbreak? And I would be looking to you. And I think a lot of school boards and superintendents are in fact looking to the state, and they're throwing their hands up because there's been very little leadership and direction. So I appreciate your flexibility, and we have to reevaluate. But my kids are older now, but if they were in school when I heard 3 kids in their class or 10 kids in their class came down with it, or their teacher, I should have some expectation, medical and scientific expectation.
So, Senator Pinsky, thank you. And, the second part of your question I didn't address in terms of the guidance for how to manage an outbreak and quarantine. There is guidance in our FAQs that was released along with the metric document. And we are working with, again, our local health departments to refine the definitions and refine that protocol to respond to outbreaks. And we continue to work with them, and that's where the consistency comes in, and so that we could together work as a team with, between the Maryland Department of Health and the 24 local health departments.
Thank you.
Vice Chair Peña-Melnick.
Good morning. Thank you, Madam Speaker and colleagues, and thank you to the Department of Health Secretary. I want to express my gratitude for the fact that you created the Latino Task Force. As you know, the Black and Latino community have been hit hard by COVID-19. In Prince George's County, that is the county with the highest number, 20,000, more than 20,000 cases. The zip code with the highest is the Latino immigrant community with 2,888 cases as of today. We know that, a lot of the immigrant community were not able to get the $1,200 stimulus check, and actually were not able to apply for unemployment, although many immigrants that are undocumented possess a permit to work legally in the United States. And actually that population contributed to the state of Maryland $139 million last year just on taxes that they paid. A lot of the undocumented immigrants who own businesses couldn't receive a federal paycheck protection loan either. Your task force is great, but it does nothing to help them keep their homes. Many of them cannot pay their rent. They don't have food. They cannot apply for social services. I know that we have asked, the Maryland Legislative Latino Caucus has written to the governor twice and has asked him to do what the governor in Washington State did, what the governor in California and Oregon did, where they actually created a relief fund and they use money from the Federal CARES Act that is not tied to restrictions on immigration status to help that community. For example, in Washington State, the governor put aside $40 million and they're giving $1,000 per individual and up to $3,000 to families. This population in Maryland has nothing. The governor has done nothing for them. Even the money that was set aside, the $30 million that is used to help people pay their rent, this population can't apply for it because the governor only used federal funds and used funds that is tied to immigration status. So this population is left basically out there to fence on their own. They are invisible, they are vulnerable, they cannot social distance, they live in crowded places. I know you're studying it with your task force, but that does nothing to put food at the table for them to eat, to survive. Many of us are doing daily food distribution, buying diapers out of our own funds to help this population. We are one Maryland, and the governor can do this. They need help now. You can study it, but they need help to pay for food. They need help to pay for their rent. And we're asking the governor respectfully to do something about it.
I'll send along the message. We are doing some things in communities in Baltimore City and I think in your county to try to help out, to try to get people tested and to try to ameliorate some of the circumstances. And I realize that that population is a lot more complicated than just testing. They do need help, and I'll pass along the message.
Thank you. And, testing is important. However, many of them go to work even though they're sick because they need to work to make ends leave, to make ends, to be able to live and survive. I mean, he needs to find it in his heart to do something about it, to create some money, like other governors are doing. And thank you for passing the message, okay?
Thank you.
In response to that question as well, I do want to thank the department in the zip code 21224. We were seeing some serious outbreaks, and there was collaboration with community partners to help support some of the multitude of efforts. And so certainly more is always needed, but I do want to thank the department for the efforts that happened in 21224 and as a model for potential expansion. Final question is Senator Lamb.
Thank you, Mr. President. Thank you to members of the department for being here. I just had some very brief questions focused on two main points. One with the rapid test, and two with the standard nasal swab test. So with the rapid test, as I'm sure you're aware, the sensitivity is much lower than the specificity of that test, right? And the sensitivity of the rapid test is actually lower than the standard nasal swab test. And so that difference there does lend itself to differences in really how it should be applied. Has that been taken into account with the methodology that's being used for this rapid test?
Right. I can.
Yes.
Yeah, Senator Lamb, this is Dennis Schrader. Thank you for that question. We are developing the protocols with our clinicians because of that. You're exactly right. And the way we're coming at this is, if there is a positive, that becomes a probable positive, and then we would have to confirm it with a PCR test. And so we will do that. And then, as you said, the specificity means there's very few type 1 errors, which would be false positives. The challenge often is the false negatives, which means that the protocols need to be, and I think Chair Pendergrass mentioned this, you need to test more often than just once. So the frequency of the testing goes up, but these tests are more cost effective. So our thought process is that that will the cost of the point of care test being lower will facilitate more frequent testing than the PCR testing. So we are building that into our protocols. Yes.
Right. So let me just cut to the chase here then with these rapid tests. Is that because the sensitivity is lower, and as you mentioned, the specificity is higher, someone who's positive is highly likely to be positive, but someone who's negative may not actually be negative. And so the instances where these types of tests would be most effective are where you can do that repeat testing, as Delegate Pendergrass had mentioned, to have repeated testing take place over time so that you can catch things that may have been missed in a false negative. Congregate facilities like nursing homes make sense to be able to do that and apply these tests in. Workplaces, unless workplaces are going to be provided a whole cache of tests to be able to repeatedly burn through, and same thing with schools, I'm not sure those are the best places if we have limited number of rapid tests for those to be applied in, for that very reason. Unless you have enough supply to do repeat testing at every workplace, I'm not sure that actually makes sense. The same thing with schools. Has that been thought through?
No, you're right. Congregate settings are our initial target, and that's the most appropriate use initially. But some of these tests are also, we're finding as we go along, have better specificity, or sensitivity. And without getting into the individual manufacturers, some are more sensitive than others. But I think as a starting point, we're focused on the congregate settings initially. There are also, we're tracking, because the federal government is pushing out these point of care tests to the nursing homes, but they're also talking about pushing out other new antigen tests from Abbott, which would then possibly go into the school. So we have to take a close look at that. But again, this is moving very fast. It's new technology, so we are monitoring the issues that you mentioned, and agree with your your analysis, that we have to be thoughtful about the protocols and the applications.
With regards to the other tests, the standard tests that the nasal swab tests that we obtained from South Korea, thank you for providing some numbers on how many were actually used. It's not clear to me how many we actually have, because there have been discrepant numbers of whether we have 400 tests or 400,000 tests or 500,000 tests, or whether those were swapped out for 400,000 instead. So can you tell us how many tests we have left of those South Korean tests?
Yeah, if I do the math, you know, we had 500,000 tests. We've used 210, which means we have 290 left.
Okay. So, you know, I would urge just a careful plan and thought moving forward with that. If you actually back calculate to the number of tests that were used per day since, let's say, since session ended on March 18th, that comes out to less than 1,200 tests per day. You know, I think that speaks to the need to have a good plan moving forward on how these tests are actually used, because that's just a small portion of the overall tests that we feel are needed out there, and that you probably feel are needed out there too. What is the plan moving forward for obtaining more of these nasal swab, the PCR-based tests, because those are kind of the gold standard that we have right now after these 290 are gone? Because we could easily see those being gone by, say, the end of the calendar year. What's the plan moving forward?
So, as you saw in our chart, our plan has been to build around the private sector's capacity. The UNB lab is a buffer for the surge, and and they have a plan that they're putting together for additional testing beyond these. These original assays were purchased when there was nothing really available. We were in a crisis. I think we're in a different place today, and the private sector appears to be managing their inventory and supply chain now, so that they're able to provide enough testing. But we still want to maintain this buffer for possible surge. The other thing that's coming is we're planning for the multiplex testing. We'll have more to say about that. I can't get into the details of that right now, but I'm sure you're aware that there's multiplex testing for both COVID and flu, and that's on the horizon too.
And let me just end on these 2 points. These are not really questions, but I think you need to think about them. You mentioned the supplies that are necessary for a vaccine when a vaccine eventually comes, if it comes, to have enough vaccines, but also the supplies that are needed for that. So syringes, for example, and freezers. We're already seeing on the supply chain side shortages of syringes, because potentially we're going to need 660 million syringes in the country to be able to administer all of these vaccines. Here at Hopkins, we're already looking at trying to procure freezers to be able to, keep that in ultra cold storage. I think the state needs to also look at that, because you're going to be fighting against other states trying to compete against tens of millions of syringes that are needed to be able to vaccinate a population. And that needs to you need to start looking at that now. The second point is, and I appreciate, what the secretary and deputy secretary were saying earlier, that there may be opportunities to reopen, or that it may be safe at some point for certain jurisdictions to reopen. And that seems to be the common refrain that I hear coming out of MDH, which I think is positive, and it's a nuanced message there. But that's not what we're hearing coming out of the governor. So the governor is really pushing jurisdictions to reopen, and in some instances are berating localities to reopen when they may not be ready to reopen. That the nuanced message coming out of MDH is not in alignment with what's coming out of the governor at these press conferences. And I would just urge that you continue to provide proper counsel in terms of the nuanced approach that needs to be taken for these local jurisdictions.
Senator, I will do my best.
All right. I did not notice we have two very brief clarifying questions, and if the answers can be maybe potentially given offline if they're more in depth, we do have a time constraint. But do want to go to Senate President Pro Tem Melanie Griffith. Senator Griffith.
Thank you, Mr. President. And my question is brief. Thank you, Mr. Secretary, and your team for the detailed information that you provided. I'm just trying to get an update, if you have one, on when we can expect Maryland's version of the iPhone app, COVID-wise, to become active. I understand there is an app that is working in Virginia and can let people know when they've come into contact with someone
What your will.
with the virus. So could you tell me where we are in Maryland with that?
Yes, thank you. Jinling Chan, Acting Deputy Secretary. So we are working with Apple right now. Some of the technology that they have is still in testing. What Virginia is using is an app-based, where they actually have to, the individuals have to download a separate app for it to work, but it needs to be connected to Virginia's system, and there was a lot of work that they've done to be able to make that integrate within their existing data and systems and contact tracing, and that's the work that we need to do still here in Maryland. What Apple has done is essentially integrated some of the functionalities that this app does into their operating system. So that's being tested, and all of those connections then made to our existing systems, like with COVID Link and other things, are currently being worked on. So that's what I alluded to earlier in my comments. So as of this time, there's not a specific time frame, because we're really beginning to do that deeper dive into the details of the technology, what that means, impacts on contact tracing, et cetera.
Okay, if you can keep us posted as your plans get more specific through the President Speaker's office, that would be great.
Absolutely.
Thank
you, Mr. President.
Thank you. And truly our final question, Senator Rosapap.
Thank you very much, Mr. President. This is way back to the charts about tracing, and I'm on my phone, so I couldn't see it very well. But it looked to me as though the tracing chart showed that in only half of the cases were you able to connect with even one person who had been exposed to the virus, which strikes me as an extraordinary, low rate. And it's kind of reflective of what I'm hearing anecdotally, that our tracing system doesn't seem to be really working. Did I understand the math right?
So which graph again are you referencing? The one about contacts reach, or?
Yeah, you got a chart where it said like a certain number of people, were tested positive, and then when you went through the chart down to you reached at least one of their contacts, it was half of only half of the people who had contracted the virus.
Right. Yeah. Right, so that is what we are able to document. So contact tracing can, if the person chooses not to name someone or refuses to,
with all due respect, I get the problem, but I just want to say the math. Your records show that in only 50% of the cases have you been able to connect with even one person in contact with an infected person.
I believe that is of the people with a completed interview.
Well, that's even worse. That means it's less than 50% of folks who you didn't even get the interview with. Okay, I don't want to.
Why don't we clarify that with you offline? Yeah. We're happy to have more details.
Senator, we'll get you some information, but that's why we're on television asking people to pick up the phone.
Well,
because a lot of people are looking at it at caller ID, and they blow off the call. And the only other alternative we have is to send somebody from the local health department to try to find this person. So we're trying to educate the public, saying this is not the IRS, this is not the police. We're trying to save your life. And
Mr. Secretary, I appreciate that you can't have perfect compliance, but I don't think this is 6 months into the pandemic. We've known tracing is critical to this, and if we're reaching less than 50% of the people, we got a big system problem here. Let's talk about it offline.
Surely.
Thank you.
Thank you, Mr. Secretary, Chief Operating Officer Schrader, and Acting Deputy Secretary Dr. Chan. Thank you for your time today. We look forward to the ongoing conversations, and certainly we'll follow up.
Okay. And our last presenter for this morning is Dr. Tom Inglesby. He is the director of the Center for Health Security of Johns Hopkins Bloomberg School of Public Health. The Center for Health Security is dedicated to protecting people's health from the consequences of epidemics and disasters. In the interest of time, I I'm going to leave it at that, have Dr. Inglesby come on to speak, and please present now.
Thank you. Can you hear me?
Yes.
Am I coming through? Great. All right, thanks. Good morning, Mr. President, Madam Speaker, distinguished representatives. Thanks so much for the chance to speak to you all. I was asked to provide some comments this morning on state trends, numbers of new cases, hospitalizations, and phase 3 reopenings. And we've already heard a substantial amount from our state colleagues, so I'll try not to repeat too much here, having just listened to all of that. In terms of, let me say a few words about state trends. Obviously, one of the most important metrics that all states are tracking now is the diagnostic testing positivity rate. As you've seen this morning, Maryland's reported 7-day average is 3.4%. The Johns Hopkins dashboard, which also collects positivity, has a different number. It's 6.4%. The reason for the difference is a little technical, but both are considered to be useful methodologies. They're measuring slightly different things, but what links both of them is the importance of week-to-week trends. This has already been covered by, I think, one of the or a couple of the questions. And the key point is if the numbers start to rise over time, that's a very concerning early indicator of change in the state. And on the Hopkins dashboard, I think there's been a modest rise in the last 2 weeks. So I think that's just worth watching carefully, especially after Labor Day weekend. In terms of the overall state incidence of disease, there are about 9 cases per day per 100,000 people in the state, and that's been talked about, with a range within the state of about 2 per 100,000 per day in the West and as high as 17 per case per day on the shore, with Baltimore City, Baltimore County, for example, being right in the middle at about 8 per day. That's a substantial improvement over the last 6 weeks, at least for some of the counties. Baltimore City was 28 cases per day per 100,000 back at the beginning of August, and now we're down to 8. I think that's a pretty substantial and dramatic improvement in incidence. Maryland is about 21st lowest incidence in the country. And so, for example, Vermont and Maine have an incidence of about 1 to 2 cases per day per 100,000, so substantially lower. But many states in the Midwest currently have much higher incidence. South Dakota has 38 cases per day. And some counties within states have dramatically higher numbers, even in the 50s or 60s. Our near neighbors, for example, Virginia has an incidence of 12 per day for the state. Delaware is 10, Pennsylvania is 6, Washington is 6. I think the highest risk activities for transmission at this point remain indoor recreational and entertainment activities, as well as indoor establishments like churches or other religious organizations where people may be gathering for prolonged periods of time together. I think the state now currently allows 100 people in an indoor venue with restrictions and 250 in an outdoor venue with restrictions. I am concerned about those numbers, but I think they do track with the numbers that other states are using. And of course, I think very, very important to be continuing to use masking and physical distancing and avoiding those kinds of venues. Certainly, if you have any underlying medical conditions or you're of older age. I think the highly publicized indoor wedding event in Maine from August is a serious cautionary tale about indoor events. The state at the time had a cap of 50 people for indoor events. 65 guests attended that wedding. There now are 176 cases linked to that one event, and that now includes a spread to nursing homes, to prison. 7 people have died from that event, none of whom attended the wedding. So I think that's an area where we need to really continue to be very, very careful with, particularly in the coming months, as more activities in the state move from outdoors to indoors. The risk of indoor activities has not gone away. It has probably gone down because the incidence of the state is going down and positivity rates have gone down, but it remains a place of higher risk. In other developments around risk that are worth thinking about in terms of trends, CDC reported this week that people who developed COVID were twice as likely to have been to a restaurant than those who didn't, and more likely to have gone to a bar or a coffee shop. Unfortunately, that study did not distinguish between outdoor and indoor events or indoor restaurants, and it didn't distinguish between bars or coffee shops. But on the basis of public health principles, prior outbreak investigations, we know that outdoors is far more far safer than indoor settings, and bars are particularly high risk because of the density of people not wearing masks, loud talking or singing going on. And I think it's really important for the public to know that just because something is now allowed to be open because of a change in particular guidance from the state or a local community, that doesn't mean that that activity is safe for them to do per se. I think they need to understand the risks of going to different organizations before they make those choices. In terms of the state's efforts to control COVID, I think it will be very important for the state health department and local health departments to continue doing their own investigations, including case control investigations, to understand where risks are coming from. While we have done, the state has had remarkable improvement in its numbers over time, we still have on the order of 500 to 700 new cases of COVID a day that are recognized, and presumably others that aren't. And the more information we can get on where those cases are coming from, the better we will be able to control them in the months ahead. So I'm strongly supportive of very, very active investigations of cases to the extent that that's feasible. I'm very supportive of the Maryland mask mandate that's in place. We're one of 32 states that have that kind of requirement, and I'm hopeful that other states will see the wisdom of that approach, and the country will move in that direction. In terms of testing overall, I think you've seen that there are about 18,000 to 25,000 tests being done every day in the state. That is dramatically more testing than was done a couple of months ago. I am excited about the potential for rapid antigen diagnostic testing to come online and to see how the state will be able to strategically use those tests. And we heard about that. That discussion occurred already today. I think it's going to be a high priority for that kind of testing to be used in institutions like nursing homes and prisons and food processing facilities, possibly universities, depending on whether or not we can get the lab requirements in place and the training in place, possibly schools, though I think it's going to be difficult to make sure that we have the right kind of people, training, equipment to get that done in schools in the near term, unless there are surprising breakthroughs in the market and in FDA's approach to this. For antigen testing to work well, I think we're going to need to have a really clear plan of action. This has also been brought up by a number of you all this morning. What should a positive test trigger? Will patients need to have confirmatory PCR testing? What is a negative test supposed to mean to people when they use it? I think it's going to need to be really clearly explained because it's got different implications than the PCR testing that we've been doing. On contact tracing, I think the specifics of the information that we saw in today's briefing show were quite valuable to see. I think on the one hand, it does show the difficulty in doing this work and how many people may not even answer their calls or provide contacts. But we do know from a variety of studies that even if we have partial success with contact tracing, that can be a substantial benefit in our efforts to control the disease in the state. So I am really very happy to see us moving forward with contact tracing. I think, of course, the state, I'm hopeful, will continue to apply resources and to try to improve the response rates through communications that were just described a moment ago. But even where we are now, I think tens of thousands of contacts have been reached that otherwise wouldn't have been reached if we didn't have a contact tracing program that was working. I just think we need to press forward with that program and see how far we can get. I'm very glad about the exposure notification program that Maryland is going to be using. You heard about that. I think that even with some partial adoption of that app, that too can be an important addition to contact tracing. I don't think we're going to get everyone to adopt that app. Obviously, many people will decide for whatever reason not to participate. But if we have a partial adoption of that app in the state, I think that can help with contact tracing efforts in a good way. On a few words about schools. At this point, it looks like most public schools are virtual in the state. There's some are doing or are planning in-person teaching in the weeks ahead, and others have set fall target dates for reopening. And my understanding is that some private schools have reopened or will be reopening starting in October. Maryland has said that less than 15 cases per 100,000 is the goal for reopening, and less than 5 really is the target for kind of full reopening. I think in general, I would prefer our target to be something closer to 8 to 10, but it is the case that there is no standard for this number around the country, and states are trying to make the best that they can, given their own conditions and their own situations. And I'm glad that the number of less than 5 is the number that 5 cases per day per 100,000 is the target that Maryland has set for fuller resumption of activities. I think that's a safer number. European countries that have opened schools without major outbreaks have, on the most part, at least where we can find documentation, have opened with numbers that are closer to 3 or 2 or 1. It's not to say that we can't open, that it won't be possible to open with higher numbers, but at least the evidence that we have so far in other places that people reference is typically in places which had low incidence when they were reopening. I think when K-12 schools do reopen, there's going to need to be a lot of close coordination between schools and health departments, local health departments, probably state health department. We know that there will be positive cases in schools, and the faster that health departments and schools can work together to devise contact tracing within that school, quarantine plans, isolation plans, the faster the school will be able to get back on its feet or decide whether it can keep going in its current trajectory or has to make different decisions. I don't have a clear sense or whether local public health agencies have the bandwidth to be able, and the resources and people to be able to respond quickly if all schools were to reopen at some point this fall. I think that's worth just kind of checking in, collaboratively around the state to see how people are doing, how health agencies are doing. There's a very time-intensive set of actions once outbreaks begin. And we've seen that many schools across the country, once having opened, have had cases and have had to either close or make very quick decisions that involve hundreds or thousands of students and all of their families, as well as the faculty. And while there's comparatively low risk of severe COVID outcomes in children, it's not zero risk. We saw a report this week from CDC that said 121 people have died under age 21 between February and July of this year from COVID. So a very small number of the overall deaths of the country, but not zero. And that was at a time when kids were less active than they are now. Starting in August and September, we've seen many more cases of COVID, and we'll have to get new information about how many of them became severe or fatal cases in the time ahead. And of course, the greater overall risk in school openings is the risk to staff or families who have older adults who would be at higher risk and people who have underlying conditions. A few last words on hospitals. We already talked about hospitals. That was discussed this morning. Those numbers, I think, are dramatically better than they were at the peak, with only 86 people in intensive care units across the state. Looking back, there have been, according to state numbers here, 15,000 people hospitalized since this started, and we now have 347 in hospital. So at this point, with these comparatively lower numbers, I don't see a high risk of sudden pressure on the healthcare system unless there are sudden big changes in policy or there are big changes in public behavior that drive cases up quickly. I think one of those changes could be the movement from outdoor activities to indoor activities. I don't think that will happen overnight, but I think we need to be mindful of that as the season changes and things get colder. I think mortality rate, I think you've discussed today, but you were seeing mortality rate differentials in the state, probably related to ages of people who are getting sick and other variables as well, with the Hispanic population in the state having overall mortality of 1.6%, African Americans 4%, white Americans 5.4%, Asian Americans 6%. So in closing, I'd say the state has made great progress and gains since the days where things were at their worst and since the summertime rise in cases. The percent positivity is down, testing is substantially increased, hospitalization rates are down, daily incidence per 100,000 is down, but I don't think we should be complacent. There are many challenges ahead, including those with reopening schools and universities and with the coming change in seasons. We have seen that this virus can come back in places in a matter of weeks or a month or two. We saw that across the South in the spring and early summer when public policies were changed relatively quickly. And we have the risks of the flu season and the cold that's coming. We also know that many people will be moving their home activities inside as well. So it's going to be very important for state and local leaders to continue to communicate about the importance of wearing masks, about limiting the size of gatherings, keeping physical distancing, and doing all the other things that have been talked about by my state colleagues this morning. And I'll stop there and see if there are any questions. Thanks very much.
Well, Dr. Inglesby, your presentation was so extensive that there are no questions. I think you covered what.
Okay.
So I wanted to thank you for taking the time and
thank you.
Sorry for the long wait. Okay. Mr. President.
Thank you, Madam Speaker, and thank you, Dr. Inglesby, for your time. And we always appreciate your presence and guidance. It is enormously helpful. Just a few closing logistical points for the upcoming weeks. At 3 p.m. today, the Education, Business, and Administration Subcommittee will have a joint briefing with the House Education and Economic Development Subcommittee on operation of public higher education institutions for the fall semester. Tomorrow at 3 p.m., the Senate Finance Committee and House Economic Matters Committee will have a joint briefing from the Maryland Department of Labor on the unemployment systems revisions. And next week, Tuesday through Thursday, the Senate Judicial Proceedings Committee will have 3 days of bill hearings on law enforcement reform bills. Copies of these bills will be available on the website in the hearing schedule at 5 p.m. today. Members, please be sure to continue checking the schedule online as the legislature is very active this fall with a number of joint and single chamber committee hearings for oversight and potential legislation. Thank you all today. And Madam Speaker, if you want to close us out. Any final remarks, Madam Speaker?
Question from Jake to
if we can unmute the speaker. There it goes.
Okay. Did you mention about when there will be a next meeting?
I did not.
Okay. We don't know at this time. Only thing I can tell the committee to stay tuned. And we have next Thursday or this Thursday. This Thursday, our police reform work group will be meeting at 1 o'clock. So as well, so on both ends. And I thank everybody. Thank you for your questions. Those who did not get the answers they want, please be in touch with the state health secretary and his office. And thank you, everyone, and continue to be safe.